So we're going to start our grand rounds today. So today we're going to be, I'm going to be discussing dusting versus basketing for kidney stones. So kidney stones have been increasing in prevalence due to increases in obesity, diabetes, metabolic changes in the past several decades. Subsequently, there has also been an increase in the rates of ureteroscopy, which is considered the first-line therapy for stones by many urologists. This has also increased with technological improvements, including miniaturization of scopes, improved optics, and utilization of the Holmium laser. Here in the graphs, you could see the trends in both ureteroscopy and as well in the past 25 years or so in various countries. You could see that ureteroscopy rates have been increasing while as well rates have been declining. The Holmium laser is the mainstay of laser lithotripsy. It was initially introduced in the 1990s. It's a solid state pulse wave laser, and stones are fragmented through the process of photothermal ablation. Essentially, a vaporization bubble forms and surrounds the laser fiber tip, which then destabilizes the stone. The amount of power provided depends on the pulse energy and the pulse frequency. In terms of laser settings, you could alter the pulse energy. Studies have shown that lower pulse energy results in smaller fragments, whereas higher pulse energy results in larger fragments. The downside of increasing the pulse energy is that you could have higher fiber burn back and risk of increased retropulsion and migration of the stone. The pulse frequency can also be altered, and a higher frequency leads to more fragmentation at the same pulse energy setting. It can also increase stone retropulsion, but not as much as with increasing pulse energy. The first generation of Holmium lasers were low wattage machines with powers less than or equal to 20 watts. And so fragmentation was restricted to low frequencies and high pulse energies. Classic fragmentation settings were a pulse energy of 0.8 to 1.2 joules and a frequency of 4 to 10 hertz. More recently, higher power Holmium systems have been developed, which has allowed for lower pulse energy settings and higher frequency settings, which has led to the development of other techniques for stone fragmentation, including the dusting technique. So there are two basic principles of stone surgery or breaking up stones. You could do fragmentation with extraction, where you use a low pulse frequency and a high pulse energy, where you break up the stones into fragments that can be extracted and use a basket and ureteral axis sheath that fits in the kidney to help with that. The other second technique is dusting, where you use a high pulse frequency ranging 30 to 80 hertz and a low pulse energy from 0.2 to 0.5 joules. The goal of this is to break up the stones into dust or sub-millimeter fragments, which then facilitates passage without the use of an extraction device such as the basket. When a survey was performed, 67% of endourologists stated that they utilized the dusting technique. So I was interested in this topic because for me, my go-to is to fragment and to basket. But when I spoke with residents from other programs, they said they would tell me sometimes that at their institution, most of their providers would do dusting. So I wanted to know what the comparative efficacy, operative time, and complications were between the two very different techniques. So there have been several comparative studies looking at this issue. The first study was a study by Shatloff et al., which was published in the Journal of Urology in 2010. it was a randomized trial comparing stone fragmentation with active retrieval versus spontaneous passage. They had 60 patients with ureteral stones that were randomized into the two groups, 30 in each arm. And they all underwent semi-rigid ureteroscopy with a 365 fiber. The laser setting, however, for both of the groups were the same and ranged from a pulse energy of 0.8 to 1 joule and a frequency of 8 to 10 hertz. Baseline characteristics between the two groups were the same. And when they looked at the dusting versus the basketing group, they found that the dusting group had increased unplanned medical ER visits compared to the basketing group, and with an odds ratio of 12.4. However, when they looked at the stone free rate and operative time, there was no significant difference. There were no differences in any of the other complication rates or ancillary procedure rates. This was a similar study that was performed in children. This was a randomized study of 100 children with ureteral stones as well that underwent dusting and fragmentation. Here they defined the stone-free status as the absence of any stone fragments on follow-up imaging at 1 week via KUB and a renal ultrasound. In this study, they also found no difference in stone free rate or complication rate. However, they did find that in the basketing group, the fragmentation time and operative time were significantly less. This third study was a study from Korea, which was a retrospective study that looked at 248 patients who underwent ureteroscopy between 2010 to 2015. 172 underwent basketing, 76 underwent dusting. They didn't specify their laser settings, just kind of described what they meant by dusting and basketing. The success was the absence of stone fragments less than 3 millimeters on CT scan at 1 month. Again, there were no difference in baseline characteristics. And when they looked at the outcomes, they found that there was no difference in the success rates, operative time, or overall complication rate. Finally, most recently, this study was published in the Journal of Urology in May of 2018 from the EDGE Consortium. This was a multi-institutional prospective cohort study of 8 centers, 5 who basket and 3 that dust. And they looked at adult patients with radiopaque renal stones between 5 to 20 millimeters that were located at or above the level of the UPJ. They got imaging at, with a KUB or ultrasound within 4 to 6 weeks. They did find some differences in the 2 cohorts, including utilization of anticoagulation, and obviously ureteral access sheath was utilized in 100% of the basketing cases, but only about 15.6% of the dusting cases. In terms of outcomes, they found that the operative time was higher for basketing than for dusting, 67 minutes versus 36 minutes. They did find that the lasering time, however, was higher in the dusting group than the basketing group. When they looked at postoperative outcomes, they defined stone free rate as no residual fragments at the imaging study of the 4 to 6 week mark. And they found that basketing had a higher stone free rate than dusting did, 74% versus 58%. However, when they controlled for stone surface area, ASA score, and prior as well, they found that there was no difference on multivariate analysis. So they concluded that, their data seemed to indicate that there were more residual fragments in the dusting group, at least on the univariate analysis. When they looked at postoperative complications or events, including symptoms, readmission, ED visit, reoperation, and complication, they found no significant difference between the groups. regardless of the method of or technique of stone surgery, stone-free rates following ureteroscopy have been subpar. Review by Ghani and Wolf that was published in the Nature Reviews Urology in 2015 looked at studies that looked at CT stone free rates. And when they looked at stone free rates defined as no fragments, they found that the CT stone free rate when there was active retrieval of fragments ranged between 55 to 60%, and when there was no active retrieval or spontaneous passage, the CT stone free rate ranged from 35 to 50%. So the next question that I had was, what is the significance of residual stone fragments? Residual fragments have the theoretically have the potential to act as a nidus for stone growth. Stone recurrence can be a nidus for infection and cause symptoms with ureteral obstruction. So I want to know, what is a clinically significant or insignificant stone? So this study was also a study from the EDGE Research Consortium that was published in the Journal of Urology in 2016. It was a retrospective review of 6 centers. They looked at 232 patients who had residual stone fragments after ureteroscopy between 2006 and 2013. The mean follow-up was 16 months. The primary outcome that they looked at was stone events. They found that 56% of their patients required no further intervention or was asymptomatic. 15% had some sort of complication but required no intervention. And 29% required some sort of intervention, for a total of 44% of patients with residual stones that experienced a stone event. Secondary outcomes that they looked at was stone passage rates. They found that it was the same regardless of the size of the stone, between 26 to 27%. And they found that in terms of residual stone fragment size, fragments greater than 4 millimeters were more likely to grow with time. They were associated with more complications and required more reintervention. Fragments greater than 2 millimeters were also more likely to grow, but they weren't associated with more complications or reinterventions. This is similar to the findings in other types of stone surgery, including ESWAL and PCNL, and it's been demonstrated in other studies looking at ureteroscopy as well. Generally, they found that about half the patients with a residual stone fragment are symptomatic or have a stone event, and about 20 to 30% require reintervention. The next question that I had was regarding the difference in costs between dusting and basketing. In terms of immediate costs, fragmentation obviously has increased costs, as with fragmentation, especially if you have a intrarenal stone, you utilize ureteral access sheath, a basket, and usually a stent. However, when you dust, all of these are optional. I just want to briefly discuss the advantages and disadvantages of using all of these devices. So for the ureteral access sheath, a study by the advantage of it in fragmentation is that it provides easier access. However, a study by Traxler in 2012 demonstrated that about 13% of patients have some sort of ureteral injury. However, a study previously had demonstrated that a stricture rate, that it only has a stricture rate of about 1.4% at 3 months. However, ureteral access sheets can also be utilized in dusting, as well as it could increase irrigation and improve visualization and help decrease intrarenal pressure, which can all help with the case. In terms of basketing, the basket can be tedious. It can lead to the wear of the flexible ureteroscope. which we have experience here at our institution. It also requires the use of an assistant. However, it can also be helpful in basketing cases and can be used to reposition the stone from the lower pole to the upper pole, or a more favorable location, or to obtain a small fragment for stone composition analysis, which is recommended by the AUA guidelines. In terms of the ureteral stent, when a stent is placed, costs, people can experience stent colic. They could, and there's increased costs that are associated with not only placing the stent, but also with removal and associated potential complications of stent colic. But the benefit is that it could benefit in dusting cases, is that it could potentially decrease possible pain from spontaneously passing fragments. So there was only one study that I found that looked at the cost effectiveness of dusting versus basketing, which was also from the EDGE consortium. This was an abstract that was presented at the AUA 2018 that looked at 159 ureteroscopy patients, 84 who underwent dusting, 75 who underwent basketing. They compiled costs of equipment, time, complications, ED visits, readmissions, and reinterventions, a lot of which they extrapolated from the literature. And they concluded that basketing had higher costs than dusting did. And the difference was mostly because of operative time. I think with all this data, each modality has its benefit, but I didn't think that there was a clear winner. I think that it's important to take both patient characteristics, stone characteristic, and patient expectation into consideration when deciding which technique to use. And a lot of the times when you're performing stone surgery or ureteroscopy, you utilize a combination of the techniques, and the two aren't always mutually exclusive. Finally, I wanted to just touch really briefly on new technologies that have been developed or has been reviewed in the literature. So we talked about altering pulse energy and pulse frequency to in terms of the laser setting. Now you could also alter the pulse width or duration. Long pulse width or duration allows for the same amount of energy to be distributed over a longer period of time. It's been demonstrated in some studies to be inversely correlated with ablation volume. However, it leads to less fiber tip degradation and stone retropulsion, and it is more promotes more of a dusting technique. The thulium laser has been utilized historically more in prostate surgery, but it's being studied in ureteroscopy as well. It's been demonstrated to minimize stone retropulsion and to improve stone ablation. The MOSIMS technology, which is a higher power Holmium lithotripsy, modulates the laser pulse to separate the water between the laser fiber tip and stone, allowing the second part of the pulse to hit the stone unobstructed. This has also been demonstrated to minimize stone retropulsion and improve stone ablation. And then finally, there has been some data on the burst laser lithotripsy, which consists of 3 individual laser pulses. The first has the most energy and the last has the least energy, and there is successive increasing pulse length, which are emitted in a rapid succession, one after another, and this has been demonstrated to have greater ablative properties. So in summary, I just wanted to review the questions that I had in mind. What is comparative efficacy, operative time, and complications of dusting versus basketing? Some studies have demonstrated similar stone free rates, but a couple have demonstrated that basketing has higher stone free rates. In terms of operative time, the EDGE study showed that Operative time is longer for basketing stones in the kidney, but there is that one other study that demonstrated that basketing was shorter in ureteral stones, and then all of the studies seem to indicate that they all have similar complication rates. In terms of the significance of residual stone fragments, residual stone fragments are associated with high stone event rates and reintervention rates, and fragments greater than 4 millimeters have been associated with increased growth complications and higher rates of reintervention. And from the EDGE study, basketing has been demonstrated to have higher costs, mainly due to longer operative time. And I briefly discussed the modulating pulse duration burst technology, Dolly and laser Moses technology, which have been demonstrated to improve ablative technique and retropulsion. Yes.
Dr. Singh and I share a feeling about this topic that it's become like the topic du jour that everybody likes to argue about. There are dusters and there are basketers, and they're in their own camps and they like to fight about it. But in reality, I think most of us kind of make a decision on the spot as to if the stone is amenable to dusting or fragmenting, or you're able to get a sheath up. Where is it? How big is it? You could even, you know, that video that was shown yesterday, we started by dusting a 16 millimeter stone down to a smaller size and then breaking it up into fragments to remove the residual pieces. There's a time and a place for it. I think the one benefit of this debate is it's kind of highlighted that there are different techniques and different settings and things like that for more, you know, the average ureteroscopic surgeon to understand that, you know, use a high energy, low frequency setting for fragmenting and a high frequency, low energy setting. I think a lot of it's to drive the technology and make people buy more expensive.
So it's interesting, kind of a comment about clinical trials, right? So in these trials, if someone was randomized to a dusting group, or if there was a 2 millimeter distal stone, they would dust that.
So the EDGE one wasn't a randomized trial.
Yeah.
It was, there are dusters and there are basketers, and they're like, this is my practice pattern, and let's see who's better.
But there was 2010 study.
The earlier one.
Yeah. It's part of
I think a big stone is easy to start off dusting, and then once you get down to it where it gets really wobbly, it's very hard to dust. So again, I don't know how you could dust a 2 millimeter stone. I mean, you just basket that out.
Right.
This is a question more for Dr. Motivadian. So we had talked once about the Moses technology. We're going to test it out here, or was there ever a plan for that? Or
so the 120 watt laser, probably the best thing for it is that you can do pull-ups. Whereas, so the
we're thinking about doing it.
But you need a high wattage laser in order to dust because of the high frequency. So if you're dusting, you know, basketing at 0.8 and 8, you're 6.4 watts. Whereas if you're at 0.2 and 50, you know, you're at 10 watts. You're at a higher laser setting. So dusting actually requires a stronger laser. The Moses technology is a different modulation of the pulse, and the one that we were testing from the VA was
shock pulse.
Yeah, no, the shock pulse is the
it was all this.
that one has a built-in Moses technology anti-retropulsion, which I think is kind of kitschy. Wasn't as strong. So I think to get the 120 watt laser here, they had to change the fuse boxes to accommodate the wattage.
Oh, really?
Only the VA or SMC.
My question is, for a lot of studies that looked at kind of like post-op improved outcomes, there were a couple things I was like confused about. One was they looked at stone-free rates based on like KV and ultrasound. I think no matter what you're doing for basketing or dusting, they found no difference too. I think it's unlikely that you're going to find a stone fragment large enough to be caught on either ultrasound or KUV. So I think it's almost like, you know, I felt like they really wanted to check where they got the CAT scans. And later on, you did talk about, I think I wasn't sure if it was referring to CAT. It said CT in there, and I wasn't sure if it was referring to CAT scans. Stone theory, and that's what it showed that like actually like half of these people all still have stones in there. You know, no matter what you do, if you go in and actively try and grab everything out. So that was kind of like an interesting difference. Like that first study kind of made like I was like, that doesn't make much sense to me. But later on, more definitive studies showed that actually there are tons of stones in almost every, no matter how you do it. So I think that was kind of interesting. But the other question I had was, I think the big difference, at least when I see the difference between basketing and dusting, is that when you basket, we fragment the stones till they're just small enough that we can get them out of the urine. And so sometimes I think there's like, it's not appropriate, but there's a little bit of a push or something to have to just pull that stone out. And it kind of just puts a little bit of extra pressure on the urine, maybe irritates a little more than we should. And I do think, in theory, in the like long term, rates of like ureteral stricture or ureteral injury might be high. I think that would be a really nice study to see between these two cases is find practitioners who commonly get renal ultrasounds like 3 or 6 months after ureteroscopy to see what the ureteral stricture rate is. Because I don't know for sure, but I suspect if there's going to be a difference between ureteral injury, it's going to be either correlated to that or to the use of ureteral access sheaths.
Well, there was that one study that I referenced that looked at ureteral stricture rates after using ureteral access sheaths, and it found that the 3-month rate was about 1%.
What was their equivalent, right?
What do you mean?
What was the
No, they weren't comparing anything. They were just looking at the rates of.
Just ureteral access sheath overall.
Yeah.
There's nothing that's specifically different between testing and basketing.
Not that I looked at.
We should do that study.